Hello, welcome to another lecture series. This is our second ECMO, talking about management on pump, complications that happen, and how to come off. Usual disclaimer, no conflicts of interest, and this information was collected by just one person from multiple different places in the year 2024, and your experiences may be different and not wrong. Checklist for the PS, Prepaid Surge Critical Care Fellow. All right, here's a list of things we're going to be talking about. Management on pump, including the flow, the sweep gas, ventilator management, and what does a lung rest mean, anticoagulation strategies, monitoring coming off ECMO, complications of ECMO, including air embolism, bleeding, clots, catheter problems, and more. So first, talking about flows and how much flow do you need on pump and why that's important. So there is some weight, age-dependent factors, but general numbers for pulmonary cardiac dysfunction are between 80 and 120 cc's per kilogram per minute. Septic shock with cardiac dysfunction a little bit higher, and then cardiac dysfunction with single ventral physiology and possibly intractable septic shock also needing higher flows, although that latter one is somewhat debated. Higher flows do decrease preload and increase afterload. This can be beneficial to some conditions, detrimental to others. For example, in severe heart failure, it may benefit you to keep the preload low, decrease myocardial load, and aid recovery. Higher flows can increase hemolysis, and so it's generally advised to just use as much as you need. Barriers to flow can be clots within the circuit or the cannulas, cannula malpositioned or insufficiently sized, cardiac recovery or competition, and then compartment syndrome, pneumothorax is tamponade, things that increase pressures in certain compartments, hypovolemia, troubleshooting problems with pressures and flows. So on this circuit diagram here, we have labeled P1, P2, and P3. Some diagrams have those numbers reversed, but the important things are that there's a pre-pump, a post-pump, and a post-membrane pressure, as well as a delta P, which is the pressure across the membrane lung or oxygenator. And so when you've got the troubleshoot problems, you might be told that there's too high of one of these pressures. P1 is high, meaning too negative. There's some resistance to the inflow, whether that's hypovolemia, tamponade, pneumothorax, the catheter's malpositioned, and the drainage holes are getting sucked up against the sidewall of the vein, abdominal compartment syndrome, clots, kinks in the line, cannula or the tubing being too small, too long, or the pump being set too high. Most of these can be troubleshooted with history and some bedside ultrasound or echo and or x-ray. Problem high P2s. This is due to some post-pump resistance, line kinking, clotted membrane, patient afterload. And this is where the delta P might come in handy. If that's really high, a high pressure drop across the membrane lung or oxygenator, there's some obstruction there, whether that's condensation or clots. Problem high P3, this is high resistance post-membrane, line kinking, catheter malpositioned, or increased patient afterload. Most commonly, the one you'll get called about is that P1. Sweep gases are generally adjusted to maintain blood CO2 in the 40s, sometimes higher, tolerated in patients with chronic lung disease. What to do with the lungs when you're on ECMO? A little bit of debate with this topic, and so this is not necessarily the only way correct of doing things. On VV ECMO, do expect your peripheral pulse ox will be in the 70s or 80s, especially in the early days. And you'll have to use some other way to monitor end organ function for adequate oxygen delivery, whether that's lactate, SpO2, NIRS, urine output, etc. There is a general consensus for providing lung rest until seeing improved aeration and not continuing to beat up the lungs, and then after seeing that, trying to do some recruitment strategies while maintaining lung protective ventilation. But what exactly does lung rest mean? There's not clear consensus. Some encourage spontaneous breathing, but there's a new term called patient self-inflicted lung injury, or PSCC, which is when the patients in dissynchrony with the vent and who have significant lung injury, then take deep inspirations, and those attempted deep inspirations can cause additional lung injury. Other folks do CPAP or a pressure-controlled mode with relatively low settings, titrated to lung recruitment. And there are also some who get extubated and are on VV ECMO with no breathing tube at all. And all of those are valid and may be dependent on the patient and the institutional practices where you are. VA ECMO typically have an oral peripheral pulse ox, and you may still be doing some lung rest strategies as appropriate. If safe to do so, you're going to want to thin the blood in some way while on pump to prevent clots in the circuit and from spreading into the body. There are different strategies to do this. It was formerly unfractionated heparin, and that still may be your initial load. But this has less predictable dosing and wide variability in pharmacokinetics. It has a risk of heparin-induced thrombocytopenia as well, which led a lot of institutions to move towards direct thrombin inhibitors, commonly bivalirudin, which have a more predictable dosing regimen. And I've included here a chart of recommendations for anticoagulation monitoring while on ECMO that may be slightly different from what your own institution has suggested, but it's just one safe way of doing things. And here's some transfusion goals for platelets and for different coagulation parameters. Also for red blood cells, recommends a transfusion threshold of 7 to 9 milligrams per deciliter for most patients, which is a more restrictive recommendation than historical, which was somewhere in the 10 to 14 range. And we found that more restrictive strategies require less blood transfusions without significantly altering outcomes. Platelets kept above 100 in a bleeding patient and 50 to 100,000 in a non-bleeding patient, and recommendations for INR for fibrinogen antithrombin are there as well. And there you'll see the same hemoglobin recommendations as well. What to do if the patient is bleeding, especially if they've had a surgery. You hold the anticoagulation for 4 to 12 hours, frequent evaluation of the need to continue holding and whether or not you're having thrombotic complications. In the CDH chapter, we talked about one way of perioperative management with aminocaproic acid and provided during and 24 hours after the surgery. You can also both initiate and run VA or VV ECMO with no anticoagulation, at least for a short time. And we talked in ECMO 1 about the pediatric series in 2023, reporting up to 26 hours anticoagulation free with minimal low rates of thrombosis or bleeding. All right, well, if you're rounding on the ECMO patient, what should you know? What flow rate you're at, any problems with the circuit, the sweep setting, FiO2, labs, SpO2, lactate, and an X-ray with catheter position, what the lung fields look like. If you're nearing to where you might be more aggressive with recruitment maneuvers. Additional monitoring, here's neuromonitoring recommendations from ELSO for neonates and children undergoing ECMO. In neonates and infants, that's to do a head ultrasound both before and after ECMO initiation, and then daily for 3 to 5 days if the initial one was abnormal or if there's a high-risk infant. The other things there, continuous EEG, cerebral NIRS monitoring, head CT, no recommendations for routine use, but to consider those, especially if there are clinical concerns. Additionally, institutions have variable monitoring, as we discussed in the previous ECMO lecture, that the ECMO circuit and the heat exchanger can mask fevers, and they are at higher risk for infection and they're immunosuppressed. While on ECMO, some practices are to perform daily blood cultures, although many are moving away from that. Some are choosing to monitor procalcitonin or other markers, or routinely doing antibiotics, which also has said is not needed. All right, ready to come off ECMO, you think? How to know when the patient's ready? Multiple different tests that could be performed: an oxygenation challenge, looking at the pulse pressure, ECMO weaning trials. VV, it's a little bit simpler. You can adjust the ventilator settings to what would be acceptable off of ECMO, and then turn off the FiO2 sweep and maintain the flow through the circuit to prevent clotting with no gas exchange. And if they're stable on that, then you can proceed to decannulation, which, if you've done percutaneously, can be a simple pull and hold pressure with the patient sitting up. VA is a little more complex, and there's more variance in how to do this. And the cannulas or the tubing nearby can be clamped with or without a bridge to keep the blood through the circuit flowing. Alternatively, the flow can be turned to the minimum amount to prevent thrombosis. And if there's question about whether the decannulation is a little dicey, you can also leave the cannulas in place locked with heparin and remove the circuit and leave those cannulas there, so that recannulation would not involve a redissection and recannulation of the same much more fragile vessels. Oxygen challenge test. You can increase the FiO2 on the vent for 1 hour and get an ABG. And this gives you a sense of lung function in achieving 250 millimeters of mercury of PaO2. Can be a marker that the weaning, the ECMO is appropriate. Limited use for patients with primary cardiac diagnosis, although it can track improvement in cardiac stun. This gets us much more of a sense of what the alveoli can get the oxygen off the vent. How to come off? Well, turn the anticoagulation off, and as I said, if it's percutaneous VV, you can get the head up and pull and hold pressure. If it's a cut down VV, or if it's VA, you're going to have to surgically explore and then ligate the vessels. Some folks do repair the carotid artery, especially if it's been a short duration and the vessel integrity has not been compromised by a long duration of ECMO, and the size of the patient lends itself more towards a repair as well. This remains controversial, and some folks feel that there's an increased risk of stroke with carotid repair due to either stenosis or intimal injury, whereas if the vessel was ligated, that would not be a risk. Sometimes the PICU will ask you, or the NICU, to exchange the venous cannula for a CVL or an HDLN, and that can be done as well without too much trouble usually. ECMO complications: bleeding, stroke, ventricular perforation, air embolism, complications of the cannulation. There's also complications of anticoagulation and of the ECMO itself. We'll talk about all that, as well as long-term complications, in these next slides. So cannulation itself, you can certainly have bleeding, you can have stroke. One particular technical error is an air embolism if you have some air going into the arterial side as well, especially, or as a consequence of carotid ligation, especially if there's not an intact circle of Willis. Ventricular perforation with the dilators or the cannula, air embolism not to the brain but to other places, arterial dissection, and specifically for femoral access, limb ischemia. It's more common in pediatrics than in adults. Complications of the anticoagulation: bleeding, about a 10 to 15% rate in the ELSA registry. Things that happen on pump: VV ECMO, hypertension, north-south, aka Harlequin syndrome, air embolism again, clots in the circuit, catheter malpositions, recirculation, left atrial dilation, as well as neurological outcomes. So we're going to spend some time on each of one of these topics. VV ECMO seems to be able to cause hypertension, which can be pretty high. No one really knows why. Likely and likely factorial. It can be difficult to treat. Recommendations are to just make sure that the patient's not fluid overloaded, and then treat hypertension with standard measures. North-south, aka Harlequin syndrome. This is less common in pediatrics because femoral arterial cannulation is less frequently performed. But this happens when the recovering heart starts to pump deoxygenated blood with a pressure that allows flow from the heart to reach the upper arch vessels to the upper half of the body, while the femoral ECMO cannula sends oxygenated blood to the lower half. Obviously, the upper half is where the brain and coronaries and a lot of important things are. Management options for this: maybe ready to come off ECMO, ideally. Otherwise, transitioning to VV ECMO or VAV ECMO with another arterial cannula, generally in the carotid, or converting to central cannulation or carotid cannulation. Air embolism, similar to the cannulation complication, air even after the cannulation is finished can get into the infusion side of the circuit, and then it goes to the lung, heart, brain, body. Generally, air in the circuit pre-membrane would get caught by the oxygenator membrane, so less problem there, although it can lead to the need to replace that more frequently. Air embolism can potentially be a complication of both VV and VA ECMO, especially if there's a PFO or other shunt, and it has very high morbidity and mortality, so requires extreme vigilance to make sure all the connectors and caps are on properly. This doesn't happen. Clots in the circuit. Another common problem can be seen as dark spots when a flashlight is used. Premembrane and membrane surface clots can cause some flow issues or need for circuit component exchanges. Post-membrane clots can cause embolic complications, and so those we have techniques to suck them or cut them out of the circuit. This has been less common with heparin-bonded circuit tubing, although it does still happen. Catheter dislodgement. Hopefully this doesn't happen to you, because if it does, it can be very hard to recover from. VV may be possible if you're able to adequately support on the ventilator, but VA, which I did see once, results usually in non-recoverable exsanguination. The vessel tends to retract and it becomes very difficult to re-establish ECMO support before the patient dies from blood loss. There can also be partial catheter dislodgement, and some of these can be warning signs before complete dislodgement occurs. You can see recirculation for venous cannulas, bleeding around the catheter. If one of the side holes, for example, has started to come out, or ventricular perforation if this is a catheter migration complication. What is recirculation? This is when part of the output from the infusion cannula re-enters the drainage cannula. Instead of going into the body where that oxygen is supposed to go, it goes back into the circuit. Recognize this by seeing increasing oxygen saturation premembrane and decreasing peripheral oxygen saturation. Properly positioned bicaval cannulas have low circulation, but this can be significantly altered with catheter malposition. Right atrial cannulas and dual sites have a little bit higher rates. It's obviously not a problem with VA ECMO, as the catheters aren't in the same area. All right, left AV dilation and thrombus. So the etiology of this is severe cardiac dysfunction in a patient on VA ECMO with high afterload, resulting in an increasingly dilated left ventricle and left atrium. The consequences of that are pulmonary hypertension, pulmonary edema, pulmonary hemorrhage, and wall distension impairing myocardial perfusion. As if your x-rays are getting worsening pulmonary edema, or if you see a dilated left atrium on monitoring echocardiogram, if you're on VA ECMO, this can be a sign that you might need to perform a left atrial drainage procedure, and this can be done in several ways. There's a percutaneous catheter you can use an Impella pump. Probably one of the more common ways is a percutaneous balloon atrial septostomy. You can also convert to central cannulation and with a left atrial drainage cannula. Stroke and neurological injury, one of the more talked about, more feared complications on ECMO. In general population, all comers, majority of studies in review reported normal IQ, although there were some that report lower, as well as an instance of behavioral problems and some with severe motor impairment. In general, though, a similar quality of life to healthy peers. And if you break that down by disease, there are some CDH, cardiac disease, cardiac arrest, ECPR, with worse outcomes compared to the mixed ECMO population. VV does have a bit less neurological risk, although still with about 3 to 5% incidence of acute brain injury, meaning ischemic or hemorrhagic stroke or brain death, which is not too different from the 5 to 8% for VA ECMO, with overall neurological complications, again, not terribly different, 16% in VV ECMO versus around 20% in VA ECMO. And then, of course, sadly, death. General population, 50 to 60% survival, usually a little bit better for pulmonary cases. And it is better in pediatric and neonatal than in adults. There's a table with overall outcomes for ECMO from ELSO. Here in the bottom right, you can see pediatric pulmonary around 70% and neonatal up to 87% survival, very good outcomes. And then better outcomes for cardiac than for ECPR. The ECPR does also include cardiac cases, and as we discussed in the previous ECMO, outcomes for cardiac cases of cardiac etiologies for ECPR better than in non-cardiac illnesses. Long-term complications, we talked about the neurological problems, neurodevelopmental delay, chronic lung disease, reduced physical growth, exercise capacity, chronic kidney disease, and this requires multidisciplinary follow-up to make sure that growth is appropriate, that kidney function doesn't deteriorate, that neurocognitive and language and motor development is going as well as it can be, that lung function and exercise capacity are getting better. Do they need additional therapy? An underlying disorder like CDH or congenital heart disease does increase the rate of complications. There is a high rate, up to 40% of readmissions in the first year, with about 3% mortality over the first year of discharge. Recommended reading, check out the EuroELSO webinar series on YouTube for additional viewing. 2 simple questions. The first is, you got called by the ECMO specialist because there are high P1 pressures and intermittent chattering or chugging of the circuit. The next best step is to give fluid, give blood, place additional venous cannulas. Some of those may be appropriate, but the correct answer in this case is D, reduce the pump speed until the flow is stable, and then assess if the patient is adequately supported on that lower flow, and if not, increase the speed, and if the chatter is recurrent, then evaluate and treat. The patient may actually need fluid or blood or albumin or something to increase venous pressure, or they may have agitation or pneumothorax or cannula malposition, intra-abdominal hypertension, etc. Try to avoid reflex just giving fluid, as fluid overload has worse outcomes for patients on ECMO or in critical care in general. You are discussing neurological complications of ECMO with a family compared to VA ECMO, the incidence of acute brain injury, whether that's ischemic or hemorrhagic stroke, for VV ECMO is much lower due to the fact that you're doing not much to the carotid, slightly lower, slightly higher, or significantly higher, and as we discussed in the recent slides, not as much lower as you might think or hope. All right, and that concludes this topic. We'll see you on the next one.